Good morning, students. We in the previous lecture we have studied about the mechanics of hip joint, the biomechanics of hip joint, where we have studied the articular structures. We have studied the accessory structures or the assisting structures which are responsible for the joint stability. We have understood the various angles of inclination, angle of torsion, angle of central edge angle, and their importance. Now today in this lecture we will continue to study about the function of the hip complex. To understand the function of the hip complex, we have divided their motion or the function into motion of femur on pelvis, that is in a condition when we walk; motion of pelvis on femur, that is when we are in standing position; and integrated function of hip joint. Then we will be talking about both hip and pelvis movement. Fine. So let us start with this lecture. Now we understand that when we are walking, in a condition in this, there is a flexion and extension motion which is taking place. Now what is a flexion? When the we talk about flexion, that is when the hip is moving anteriorly, that is the hip is, or the leg. If I take this is the hip, this is the leg. When you understand this, that is the convex surface is moving on a concave cavity. Herein the arthrokinematics will be opposite to that of the osteokinematics. The flexion and extension is taking place in sagittal plane, and if this is taking place in the sagittal plane, that means it is taking place in x-axis. And the flexion extension movement, as we described, the femur is moving in flexion, the femur is moving anteriorly, femur is moving or the leg is moving anteriorly. Fine. When the head is or the leg is moving anteriorly or away from the body and anteriorly, then the head is moving posteriorly. It is rolling anteriorly but sliding posteriorly. Fine. So this is for the movement which is taking place. That is, let me go through this. It is a sagittal plane coronal axis, flexion 90 to 120 degree, and it is 90 degree with knee extension and 120 degree with knee flexed. Extension, it is again when the leg is moving posteriorly, and herein the head is sliding anteriorly, and the arthrokinematics convex concave rule is being followed over here. When flexion, the distal end of the femur moves forward and the articular surface moves backward. When the distal surface is moving forward, you can see the articular surface is moving backward, and when the distal surface is moving backward, the articular surface is moving forward. Now there is an important point which I have written over here is 90 degree of knee flexion with knee extension. Now what is that? That is when the knee flexion takes place. We have seen that when you are in a supine lying position and when you try to flex the knee, it is maximum you get it as 90 degree. Beyond 90 degree you cannot do, but you understand the hip flexion ranges goes up to 120, 130 degree. This is only possible when we bend the knee. As soon as we bend the knee, the hip range increases to 130 degree. This is because of the again the role of hamstring muscles, that is it is responsible, that is the two joint muscles which are responsible for bringing about this movement. For example, in this herein this is the role which will be I will be talking about all these two joint muscles. Their two joint muscles are hams, quads, you can say gracilis, tensor fascia lata, that is for adductors and abductor group of muscles. They all will be for the flexors as well as for the extensors. All they are two joint muscles. So these two joint muscles, they affect the range of motion. So if we are reducing their motion, or if we are bending the knee or reducing the movement or their passive stretch in the second joint, the first joint range of motion is increased. Fine. The abduction to adduction range takes place in frontal plane and that too in z-axis, and the abduction range is 40 to 50 degree when the distal end of the bone moves away from the midline, and there will be the spinning movement is opposite. That is, if the abduction, if you can see, the head is, if the head moves, that is the head is moving inferiorly, whereas the distal end or the shaft is moving away from the midline. That is, the shaft is moving away from the midline superiorly and the head is moving inferiorly. Whereas in adduction, the head is moving superiorly, the shaft is moving inferiorly and medially. Fine. So this is the movement, that is glide and spin is taking place again opposite, and the adduction is taken at a range of 20 to 30 degree. Now what about the internal to external rotation? The glide and spin mechanism again is opposite. If the medial rotation is taking place, you can see this is the motion. If the medial rotation is taking, the head is moving posteriorly, as well as the glide is taking place anteriorly. Fine. So the glide and the spin is again taking place in transverse plane and vertical axis, and the angle is 40 to 50 degree. Now I have told you about this. It's a two joint muscle. Basically reduces the range of motion of hip joint when they are stretched. Like gracilis, it will can reduce the abduction. Now you understand this position, that there is the hip abduction is also at an angle of, you can see, 45 degree. Now 45 degree is there, but you know that the hip abduction can go up to 90 degree also. So fine, this is the action of gracilis group of muscle, and if you can take that into account, then again for the TFL is responsible for bringing about the adduction movement. Fine. The hamstring is bringing about the knee flexion movement, as well as the rectus femoris is bringing about the hip, checking about the hip extension movement. Fine. So keeping this mind that two joint muscles are passing through it, we can know the active and the passive insufficiency of the muscle, and which we have already discussed in detail about in my previous videos about these two joint muscles. Fine. Now the second motion, this was the motion of femur on pelvis. That means how the femur is moving when we are walking. That is, the pelvis is stable and the femur is moving, that the distal is moving. Now we are seeing that is when the pelvis is moving and the distal part is stable, that is in condition like standing. So there is some tilts which are happening at the level of pelvis, which is called as anterior and posterior tilt, lateral pelvic shift, and forward and backward rotation. Some part of it we have already studied in the biomechanics of gait, but we will try to see it in detail over here. Fine. Now in this figure you see the motions which are happening over here. In the first motion is the anterior and posterior pelvic tilt, which takes place in sagittal plane. Which takes place in sagittal plane. Fine. This is the anterior pelvic tilt and this is the posterior pelvic tilt. The anterior pelvic tilt is we take into reference, if I can show you over here, we take into reference the ASI, the anterior inferior iliac spine. Fine. What we do is, there is we take one horizontal line. One horizontal line is passing from the anterior part, and you can see, if this is the bone, if this is the surface, this is the anterior superior iliac spine, this is the posterior superior iliac spine. When we stand and we place our hand on our waist, the thumb is basically placed on the posterior superior iliac spine, and the index finger is placed on the anterior superior iliac spine. So this is how you recognize these two anatomical landmarks. So if I can show you on bone, you can see anterior superior iliac spine and posterior superior iliac spine. So this is a vertical line. So to understand the motions at the pelvis, you have to understand this is a vertical line, and there is a line between the anterior superior iliac spine and this pubic bone. Fine. This pubic bone, there is one you can say horizontal line, and one there is a vertical line. If you can understand these two lines, you will be able to understand the motion of the pelvis. So we take this two into a reference point. Now if this is the bone, if you can see, this is the bone. Now what you will see over here, I am holding this bone. So anterior pelvic tilt means that there will be the what will happen to the anterior part. You have to see over here, the anterior superior iliac spine moves anteriorly, whereas the pubic symphysis move inferiorly, and the posterior iliac spine moves superiorly. Can you see? This is the motion which is happening. This is the motion which is happening. That is, the anterior inferior iliac spine is moving anteriorly, the pubic symphysis is moving inferiorly, and the posterior superior iliac spine is moving superiorly. And this is the anterior tilt, and it is accompanied by hip flexion. It brings about hip flexion. Fine. What will happen in posterior tilt is, again the movement we are taking is the anterior inferior anterior superior iliac spine is moving posteriorly, the pubic bone is moving superiorly, and the posterior inferior iliac spine is moving inferiorly. So this is how you define these movements, and there is accompanied by hip extension. Fine, I think this is clear. This is called sagittal plane and axis movement. The second movement which we see over here is which takes place in the frontal plane. Now this is a very important movement. So herein you can see that there is tilt, there is a kind of a tilt, lateral shift or lateral tilt, pelvic lateral tilt. Fine, movement is taking place. Now what is happening is there is the movement is hip hiking and hip drop. Hip hiking and hip drop, which happens when you are in a unilateral stand. When you stand on one limb, what will happen is in order to balance the pelvis, every time the aim of the body is to maintain the balance or maintain the two lines together. In order to maintain the two lines together and in order to reduce the joint compressional forces, the pelvis, the opposite side pelvis, that is opposite to what happens is, if the right limb is weight bearing, the pelvis, and you have folded the left leg, so what will happen is the left hip pelvis will hike, the left will hike. This will bring about, the hiking will bring about an abduction movement of the non-weight bearing pelvis or non-weight bearing leg. And the hip hiking is brought about by the abduction movement, and the weight bearing leg will have an adduction movement. Fine. So this is the movement, that is the dropping will bring about adduction movement and the hiking will bring about the abduction movement. So this is a simple can be there is, if in a unilateral stance the pelvis, you are standing on the right leg, the opposite side pelvis will either hike or either drop. The hiking is accompanied by abduction and the drop is been accompanied by adduction. Simple as it can be. The third motion which is there is in the horizontal plane and transverse axis, which is the rotational movement. Now this takes place in bilateral stance when we are walking and we are basically in a double limb support. In double limb support, what happens is when the right foot is ahead and the left foot is behind. So what is when the right foot is ahead, the weight bearing is the left foot. So the right foot is basically forward, there is a forward rotation of the pelvis. The right foot is as the leg is ahead, so it brings about a forward rotational movement of the right hip. This is the rotational movement which takes place of the right hip and bringing about medial rotation of the femur. Whereas yes, this is bringing about the medial. When you are for the left foot, if you consider the point as for the left foot is going into backward rotation or and it is bringing about lateral rotation or external rotation of the femur. So you can see there are two motions which is happening, one at the pelvis and another at the femur, which is happening over here and in different planes. Now let's go through this. The anterior posterior tilt, the sagittal plane coronal axis, anterior tilt. ASIS moves anteriorly, pubic symphysis inferiorly and PSIS move up. It is accompanied by hip flexion, and posterior tilt and ASIS move superiorly, pubic symphysis move superiorly and PSIS move posteriorly. It is accompanied by hip extension. Now lateral pelvic tilt, it takes place in frontal plane and AP axis in unilateral stance where the left leg is weight bearing and the right leg moves upwards, that is hiking, and it can drop, it can hike and it can drop. With hike there will be adduction movement of the hip, and with drop there will be adduction movement at hip also. Fine. And in lateral pelvic shift, there is another condition which is called as lateral pelvic shift, which takes place in bilateral stance. Now what happens over here is, we have talked about the unilateral stance. What happens in bilateral stance is, when the right foot is forward with the hip flexion, whenever the right foot is forward, there is kind of a hip flexion, knee flexion, and the weight shifts to the left side. And the left side is basically the pelvis moves laterally. It displays, where the weight takes place on the left foot, it moves laterally. That is called as lateral pelvic shift, and it brings about an adduction movement of the left side. It also brings about an adduction movement of the left side. This lateral pelvic shift takes place in bilateral stance, whereas the lateral pelvic tilt takes place in the unilateral stance. Now backward and forward rotation also takes place in transverse plane and vertical axis in cases of unilateral as well as in bilateral stance. There is anterior movement is brought about by the medial rotation of the leg, and posterior movement of the pelvis is brought about by the lateral rotation of the leg. Now very important point to be taken care of is integrated function of the hip complex. Now the hip flexion and the anterior pelvic tilt takes place simultaneously. The hip extension causes posterior pelvic tip. Abduction and adduction movement is controlled by the lateral tilts, and the medial and lateral rotation is controlled by the forward pelvic rotation and the backward pelvic rotation. Now integrated function can be explained as an open kinematic chain and a closed kinematic chain. The open kinematic chain, we see it as a lumbopelvic or pelvic femoral rhythm. We say it as pelvic femoral rhythm. Fine. That is, the motion of the pelvis is on the femur in rhythmic way to increase the range of motion. That is, interconnection link between the pelvis, hip and limb and the lumbar spine. This is called as the open kinematic chain. The chain between the pelvis, hip and the lumbar spine is said to be, so that improves the motion or increase the mobility of the structure of the body. That is called as pelvic femoral rhythm. Fine. That is, if you want to reach for an object while forward bending, there is a we forward bend and try to pick a book from the floor, then what happens is, first the hip flex, then there is an interior pelvic tilt, and then the lumbar flex in order to reach to the floor, because hip flexion will takes place at one level. After that, there is movement, interior tilting of the pelvis will take place and lumbar flexion takes place. This is the integrated motion. Or in hip abduction, pure abduction is only 45 degree, but we can take it to 90 degree. This is only possible because we have done is lumbar side flexion. You understand? So this is the open kinematic chain motion which takes place. And as you can see, this is how the hip motion, first the hip flexion is taking place, then interior tilt, and then the lumbar flexion has taken place, so that we can lift an object from the floor. This is pelvic femoral rhythm. Now in closed kinematic chain is a condition in which the both open kinematic chain is a condition when the distal end is free. You can see in this position the distal end was hands and the head was free, so therefore the movement was taking place. Now if we consider that there is a wall which is on the head, as well as the head is again stabilized, as well as our feet is stabilized at one position, then what kind of a mechanics will take place? That is called as closed kinematic chain mechanics. And when the body tries to maintain, now we are trying to maintain our position, it tries to maintain the head over the body. So in bilateral stance position, what happens is that the hip flexes, you understand, and the pelvic there will be pelvic interior tilts takes place, and the lumbar, it goes into flexion, and then also the body now tries to maintain. Now if this structure is not allowed to move forward, what will happen? It is stuck. That is, if I take this wall, the roof which is stuck over here, and of course the floor, I am stuck in between, then what will happen? Now when the hip flexion, I am taking a step, the hip flexion takes place, the anterior tilt of the pelvis will take place, and the lumbar will flex. But if the lumbar flex, the body will try to now give a compensatory movement at the lumbar spine. There will be lumbar spine extension. This compensatory changes which takes place, which happens only in a closed kinematic chain, because what is the primary movement is hip flexion, then is the accessory movement is interior pelvic tilt. Now rather than hip flexion, now hip extension takes place, and I try to maintain my body, I try to maintain my head over my body. In order to maintain the head over the body, the third compensatory movement which happens is lumbar extension. This is a closed kinematic chain, that is the movement of the pelvis, integrated movement of the pelvis on femur. Can you see the normal, it was hip flexion, anterior tilt and lumbar tilt when the open kinematic chain was there. Now in a closed kinematic chain, you can see the hip flexion will bring about interior pelvic tilt, but there will be compensation by the lumbar lordosis. Fine. Now another thing, very important point in the hip complex is, since it provides stability and the chances of degeneration is so high, so we need to understand the kind of joint compressional forces which are acting, and what are the how the different positions, in different positions the joint compressional forces changes. We need to calculate that. That is a very important thing to understand, because we prescribe exercises and we prescribe various positions to the to patients who come up with painful hip or any conditions with the muscle aches. So if we understand it well, we can prescribe the exercises also very well. So for this, we need to understand the forces acting across the hip joint. So that means we know the forces which are acting around the hip joint are only three forces. You understand, this is the body weight which is acting downwards, then there is a ground reaction force which is acting upwards, and there is an abductional force. Can you see the abduction force? This is the abduction force which is acting and abductor group of muscles which are acting. So if we take it, it acts as a lever. You can see it is acting, the fulcrum is the hip joint. You can see it is acting as a lever system. The fulcrum is the hip joint. The action is, effort is being produced by the abductor group of muscles, and the weight is the weight of the body. So you can see this is acting as a lever system. So there is a body weight, there is a fulcrum hip joint, and the abductor group of muscles are acting. Fine. So these are the forces which act. So joint reaction forces defined as a force which is generated within the joint in response to the forces acting on the joint. So in this hip, it is a result in need to balance the movement arm of the body weight and abductor tension. So in order to maintain the pelvis. Now basically this joint reaction force is to maintain the pelvis, neutral position of the pelvis. These forces are acting. Fine. So this joint reaction force is 2 times of the body weight during SLR. It is 3 times of the body weight. This is very important point which I want to show it to you. It is 2 times of the body weight in SLR. It is 3 times of the body weight in single leg stance. It is 5 times body weight in walking and 10 times body weight in running. Can you see how much joint reaction force is acting on the hip itself? Fine. So now let us see and calculate the force which is acting through the hip joint in bilateral stance. Now you understand, simple thing is that you understand this is the weight which is acting. Okay, now this is the weight, this is the body weight which is acting down. This R is the movement arm. This R is the distance from the center to the center of the head. From the weight to the center of the head is the distance, and the center of the head is the you can say this is the movement arm. You can see this is the right, this is the left side. Fine. And this is in bilateral stance, you see that the weight is acting in the center. The distance on the right side and distance on the left side is the same. There is no change in the distance. So that means the weight, that is the body weight, is equally distributed, half and half, equally distributed on both the sides. Since the movement arm is same, the body weight is equally distributed between the 2 half. Fine. So let's go through this again. The line of gravity passes posterior to the hip joint and brings about gravitational extension movement at the hip and causes posterior pelvic tilt, which is maintained by the capsulo ligaments of structures. Okay? Now if we take a person with the weight of 120 Newton and the weight is 120, and we can say that if we understand the body weight is which is acting on the body is 2/3, that is head, arm and trunk is said to be the 2/3 of the body weight, and the less 1/3 is of our both the limbs. Fine. So we say that 2/3 of this is 2/3 of the body weight. This is basically 2/3 of the body weight, that is of head, arm and trunk, which is acting on the body. And if the 2/3 of the body weight is, that is if I do 2/3 of 120, I find this to be around about 80. Fine. You can see it is 80 Newton which is acting, and now this 80 Newton is divided equally on both the side. Can you see? This is equally divided on both the side, that is 40 here and 40 here. Why so? Because equal distribution of 2/3 of the body weight is taking place. So that is why I have written 40, that is half of head, arm and trunk on each limb is 40. Now 40, and you understand the weight is equal, 40 on the both the sides. The movement arm is also the force which is acting is, you can see the movement arm is same, right and left side the movement arm is same. So the torque which is acting, adductor torque which is acting is also the same. Now that means we can say that the torque is if I can say torque is equal to force upon movement arm. Na? This is the upon the movement arm. This is the area which we need to find, and if we see that the movement arm is same, so the torque is always the same, the force will also be the same. That means we say that the torque which is acting on the right side is similar to that of the left side, and we see that the joint compressional forces which are acting on the hip is 40 Newton, and it is more stable position for the hip joint. Now let us see what will happen in condition of unilateral stance. Now when the unilateral stance is when the right side of the hip is weight bearing. Fine. And if what will happen over here? If we see this, Again, the weight of the body, we have taken a patient's weight as 120 degree, and we see that the head, arm and trunk weight is 2/3 of the body weight, and remaining 1/3 of the body weight is of the two legs. Fine. So the total compressional forces is 2/3 of the body weight plus 1/6 of the left leg. Now you know the right leg is weight bearing, and the 1/3 is basically you have to do is 2 times, that is like this, and it comes out to be 1/6. 1/6 of the left leg, that is 1/3 is divided, 1/3 is for the both the legs. So you have to, if right leg is weight bearing, so it is taking the weight of the left leg also. That is why 1/6 is been added over here. 1/6 of the left leg is added over here. So that is, we now to see the kind of weight which is passing through the right leg is 2/3 of the body weight, that is of head, arm and trunk, and 1/6 weight of the left leg is also passing through. That is why 5/6, and 5/6 of again 120 is into 120 is, that is roundabout, you can see is 100 Newton. Now there is a development of adductor torque to compensate the trunk fall. You understand there is a gravitational adductor torque is there, and otherwise the trunk will fall in this condition. Therefore the muscles which control them is the abductors group of muscles. So we are going to find the gravitational adductor torque. Now gravitational adductor torque is the weight which is passing into the movement arm. That is the weight which is 5/6 of the body weight we have already seen, and the movement arm of adductors is assumed to be 10 centimeter. Fine, herein we have assumed it to be 10 centimeter. In the diagram over here, we have already said over here the moment adduction torque. We have already assumed over here that the adduction torque is 4 inches, as well as the abductor torque is 2 inches. We have already assumed over here. Fine, so that's why we have taken this. So in this condition you can see that we have taken 10 centimeter. The torque, adductor torque is 10 centimeter. So we have multiplied 100 newtons with 0.1 meter, and we have got 10 Newton meter as the gravitational adductor torque. Now the gravitational adduction is 10 Newton meter, and now we want that the abduction force should compensate for this adductor torque, so that we are able to maintain the pelvis. So that is against, we know that, we understand that we are maintaining that unilateral stance. So we know that this is amount of torque. We are now, this torque is available to us. We know the movement arm of the abductor group of muscle, which we have taken as now 5 centimeter. That was 10 centimeter, and this is 5 centimeter. You can see 0.05, and we know the torque is 10. So 10 force is equal to, we understand this is, so the force is equal to torque upon movement arm. So we have seen over here is 10 divided by 0.05, 200 Newton meter. And if we see the total hip compressional forces is compression by the body weight, which is come out to be 100. This is 100. So this is 100, and the compression which is brought about by the muscles is 200. So the total torque or the total joint compressional forces is 200 plus 100, 300 Newton meter forces are acting when the joint on the at the joint of hip joint, when there is when you are in a unilateral stance. Now whenever you are in a unilateral stance, there is a tendency, or when you are in a pain at hip, what you do is the trunk side try to lean on the same side. The trunk will lean onto the same side. So in that condition, let us see what is the joint compressional forces. If the patient's, that is, the patient is leaning. Now when you have a painful hip, the patient is leaning towards the or trunk is leaning towards the hip side, so the line of gravity is moving near. So the movement arm has reduced from 10 centimeter, that is 0.1 meter, to 0.25 meter. We have assumed this because it has reduced. Therefore the adductor torque has also reduced to 2.5 meter. And the abductor torque we have calculated is 50 Newton meter. The adductor torque is 50 Newton meter. So the total compressional forces is 100 Newton meter, as we have calculated it on the joint in the previous unilateral stance, and the 50 Newton meter, that is 150 Newton meter. That is why the patient always leans whenever he is having antalgic gait or painful hip. The patient leans towards the painful hip side, because he tries to reduce the pain or joint compressional forces which is caused because of AVN. Fine. So this happens. What we recommend? We recommend to use a cane. Now this question is whether the cane is on the same side or on the opposite side. We will see for the joint reaction forces over here. Now if we are using a cane, the transfer of 15% of weight will be on the cane. So now the joint compressional forces by the weight is 5/6 of the body weight minus 15%, because the 15% has been transferred to the cane. We know that 5/6 of the body weight is 100 minus 18, that is 82 Newton. Now we have to see the adductor torque. The adductor torque for the is the same, that is the force, that is 82 Newton, that is the weight which is passing through the hip, and the moment arm which is 0.1 meter. Fine, we are not taking into consideration the trunk movement here. Fine, so that is why normal the movement arm of the adductor muscle was 0.1 or 10 centimeter, so 0.1 meter, so it came out to be 8.2 Newton meter. And we know that the abductor torque is compensating for the adductor torque, so by this we have calculated the force which is acting by the contraction of the muscle will be roundabout, which is 164 Newton meter. So the total compensation is 82, which is the weight of the body which is passing through, and which is due to the 164 is due to the contraction of the muscles. Total is 246 Newton meter joint compressional forces are acting on when the weight is on the ipsilateral cane. When the cane is on the contralateral side, then what happens? Then the body weight is shifted to the cane 50% similarly, and the adductor torque, if we want to calculate, it is on the same line, that is 5/6 of the body weight minus 15%, and which is 100 minus the 18, which is 82, minus multiplied by the 0.1, that is the moment arm, which comes out to be the same. Adductor torque is 8.2. Now the cane has helped us to prevent this adductor torque. That means the cane is compensating for the adductor torque. Now let us see how it is compensating. Now the torque is of the cane. The cane is producing the force into movement arm. That is the force which is been 18%. We have seen 18. The 15% of the weight was acting on the cane. 18 multiplied by 0.5 was the distance at which the cane was kept, the movement arm, which came out to be 9. Now we see that this cane torque is more than the adductor torque, so it nullifies, the muscle contraction nullifies. There is no abductor torque over here when we take the cane to the ipsilateral side. Fine. So what happens is the total compressional force is only the weight of the body. There is no compression due to the muscles, so it is only 82 Newton. So you can compare this. It is 82 Newton in contralateral side and 246 Newton in case of ipsilateral side. So if we can revise all this, you can see that in bilateral stance there were 40 Newton which was acting on the hip. In unilateral stance is 300 Newton meter force is acting. In leaning towards the same side, 150 Newton force was acting. In ipsilateral side, 246 cane if placed, 246 hip joint compression force is acting. On contralateral side, 82 Newton force is acting. So you can now say the reason why we give a cane come on the contralateral side, not on the ipsilateral side. Fine. Now with all this kind of joint reaction forces, I want to wind up the hip joint by just telling you about few more points. One is about the hip flexors, now the stabilizers, because since these are all these are two joint muscles. So they are, these all are two joints, psoasmajor, iliacusand we basically say, rectus femoris, sartorius, TFL, they are all two joint muscles, and they are responsible for bringing about the range of motion. Fine. If we are able to move, if they are stretched from both the joints, and if the muscles are stretched at both the joints, the range of motion at one joint will not be the full. It is as clear as it can be, because if it is lengthened at both the joints, it cannot produce the same range of motion for both the joints. So it need to relax at one joint so that the range of motion of one joint other joint can be increased. So the first which I want to say is about the psoasmajor muscle. If you can see over here, the psoasmajor muscle is there, then you can see this is the muscle. It is basically arising from T12 and up to L5. It is arising from here, okay? And this is the iliacus muscle. Fine, this is the iliacus muscle. The psoas muscle is basically major and minor muscles. They are arising from here. Fine. So this is the origin, and then they are responsible for the hip flexion. So psoas muscle basically acts, major muscle acts when we apply resistance to hip flexion. Fine. So it brings about lateral rotation also. So it is basically, since it is arising and from the lumbar spine, so it brings about lumbar stabilization also. Okay, so it brings about lumbar flexion also. Fine. So it has got lumbar stabilization action, lumbar flexion action, and it is a resistance of hip flexors. It comes into action when you provide hip resistance, and then it brings about little bit of lateral rotation also. Now pathomechanics of psoasmajor muscle is that there can be weakness of this muscle. If there is a weakness of this muscle is there, then it is very difficult. How do we identify it? It will be very difficult to achieve maximum hip flexion. Now it is mostly at the 5th decade of life. The person will say, I have difficulty in climbing stairs, or getting up from a bathing tub, or getting out of the car, or releasing the foot from the clutch and the brakes. So this is a kind of a weakness of which muscle? The psoasmajor muscles. And if there is a tightness of the muscle, what will happen is the hip extension will be restricted, the pelvis will be anteriorly tilted, the lumbar will be flexed, and compensation, if this is a close kinematic movement, then lumbar lordosis will also take place. Fine. Now iliacus muscle, as I told you here, this you can see is minor, this is major, which is getting attached to the lesser tuberosity, and this is iliacus group of muscle. Now what is the weakness? It is also responsible for hip flexion. Now this is, if weakness of hip flexors over here will have less hip flexion, but there is something important is the gravitational extension at hip, the tendency to fall backward will be there. Now there is a difference between the two. Understand, when the psoasmajor weakness was there, the person was having difficulty in getting up from a high hip flexion position. So there was a difficulty in that, or if there was a chances of getting raising up from the car, or from the sitting position. But here the problem is that the tendency is to fall backwards. Here is because it is restricted. The hip basically the hip extension is restricted by the capsular ligaments, which is called hanging on ligaments. And in cases of spinal cord injury, these ligaments, you find the person is in posterior tilt itself, in hip extension itself, because the hip flexor muscles are not acting, that is our iliacus is not acting. That is why you see the person in posterior pelvic tilt at hip extension. Now if there is a tightness of the muscle, you know that there will be decrease in the hip extension, and here in the pelvis will move in anteriorly. Fine, the pelvis is moving here in interiorly. Now there are two conditions which can happen over here when there is a tightness of iliacus group of muscle. One condition is the pelvis can go into lordosis. When the pelvis is that is, there is no hip extension taking place, so that means the pelvis has moved anteriorly. If there is increase in lordosis which is happening, now what will happen is there will be increase in facet joint arthropathy. The compression of the facet joint will increase, because what is happening is the hip extensors are not there working. So hip is going into flexion, the pelvis is moving anteriorly. There will be two conditions. The lumbar will go either into lordosis or either into flattening. If it goes into lordosis, the facet arthropathy takes place, because the facet joints goes into compressive forces and the facet joint arthropathy takes place. If it goes into flattening, then what takes place is that if the abdomens are good, they will take the load and IV disc degeneration will take place. That is, there will be compression of the IV disc, that is PIVD. Fine. If it is flattening, the abdominal muscle will take load and there will chances of developing PIVD. So you can understand the change in the pathomechanics, the role of psoasmajor muscle. I want to show this again. Now in psoasmajor pathomechanics, the weakness was difficulty in climbing, and there was a restriction in, you can see, hip flexion, and there was no compensatory changes in the lumbar spine. Why so? Because it was stabilizer of the lumbar spine and it is bringing about flexion of the lumbar spine. But iliac muscle is not arising, it is arising from the iliac crest, and it is going to the lesser tuberosity. So there is no role of lumbar spine, and herein you see the compensatory changes which are happening here is at the lumbar spine. Either it is facet joint arthropathy or there is a disc prolapse which is happening, which is because of the compensation. Fine. So this is how you can understand the pathologies. If you know good the muscles, if you know the origin and insertion of the muscle nicely, you can understand the pathomechanics and you can understand the conditions. Now, tightness of hip flexion contracture, if there is a bilateral tightness, which is seen in truck drivers and students who have got sitting position, so there will be a bilateral hip flexor tightness. Unilateral hip tightness takes place in arthritis. Now what happens is, either the trunk will move towards the femur, that is in bilateral tightness, the trunk will move towards the femur, the person will walk in this position, whereas otherwise there will be the femur will move towards the trunk. Fine. And in this condition, what will happen is, there will be, if the femur is moving towards the trunk, what will happen is, that is the hip will go into flexion, knee will go into flexion, and foot will go into plantar flexion in order to maintain the limb length. There will be a limb length discrepancy. Unilateral side, there will be a limb length discrepancy, and there will be a compensatory movement. The foot will go into plantar flexion, hip will drop, so that in order to maintain the limb length. Fine. So these are the changes which happens. Similarly, you know about the rectus femoris. The rectus femoris muscle, they are responsible for bringing about the hip movements, and it is again a two joint muscle. You can see it is the vastus medialis, vastus lateralis, vastus intermedialis, and the rectus muscle. So it is a primarily it brings about hip flexion and knee extension. So if we know that hip flexion can be only 90 degree when the knee extended, and as soon as you bend your knee, it can range of hip flexion can reach up to 130 degree. So this should be kept in mind when you are going for the hip range of motion. Find sartorius muscle, which is arising again from the, you can see from the iliac crest, and it is going posterior superior iliac spine basically, and it is going and inserting at the pes ansaris. So you can see this is a talar muscle, or you can say it is a ribbon like muscle which is passing through. So it is bringing about this movement, which is the adductor movement, and this is again passing through the knee as well as through the hip. So it's the movement of the, it is bringing about hip flexion movement, as well as a rotational movement is also taking place. It is a good medial rotator. Fine. And tensor fascia lata, if you can see, it is running from the iliac spine and going up to and getting inserted on the lateral side of the you can see this is bringing about the adductor movement as well as the lateral rotator movement. So hip is a hip flexor as well as brings about the lateral rotator movement. So this is the kind of compensation you can two joint muscles does. Fine. Similarly, hamstring group of muscles, it brings about hip extension and knee bending. So the range of motion of hip extension can be increased. You can see it is only 30 degree with knee extension, and it increases when you bend your knee. So you can see that the range of motion of the two joint muscles changes with the when it has been stretched at both the joints. Fine. I hope you have understood this hip joint complex. I have tried to cover all the aspects of it. If you find any doubts, you can please post it in the comment section, and best of luck. Thank you.